I'm sorry that I could not be with you at this meeting. In addition, I would like to thank Ayman Fakhri and the organizing committee for the honor and privilege to present to this prestigious audience on gold standard and new superficial venous devices undergoing trials. Could they be game changers? These are my disclosures. What is important to you regarding ablation? Closure rate, patient acceptability, cost, affordability, cost effectiveness, profit, reintervention rate, complication rate. We know that one size does not fit all, nor is one thermal or non-thermal device perfect for all cases. What is the definition of gold standard? It denotes the best tool available at the time to compare different measures. Who is in control of the gold standard? Or who is in control of what devices we use? I would hope it would be the doctors. However, we know better. We may have influence, but in the US, it is controlled by the insurance industry and the government. One of the first randomized controlled trials comparing different ablative devices concluded endothermal was superior to foam and surgery. So let's look at the literature. In 2017, Enrico Asher and Anil Hingorani wrote Clinical Correlations of Success in Acute Thrombotic Complications of Lower Extremity Endovenous Thermal Ablation. And they found that there were no differences in efficacy between RFA and laser. In the Journal of Angiology, Professor Alan Davies concluded that thermal treatment with RFA or endovenous laser ablation is the mainstay of varicose vein treatment. Both RFA and laser appear to have similar efficacies. Looking at laser, RFA, and foam sclerotherapy, Professor Bittenden reported in the New England Journal of Medicine in 2019, looking at 5-year outcomes, that disease-specific quality of life 5 years after treatment was better after laser ablation or surgery than after foam sclerotherapy. The majority of the probabilistic cost-effectiveness model iterations favored laser ablation at a willingness to pay ratio of approximately 20,000 pounds or $28,000 per QALY. Now let's look at non-thermal, non-tumescent treatments. Does size matter? It appears to, as the non-thermal limitation by the FDA trials were less than 12 millimeters. The new European Society for Vascular Surgery 2022 guidelines support thermal ablation for great saphenous vein. Treatment is the gold standard. As you can see, the first tier is thermal ablation. The second tier is surgery and glue. And the third tier is mechanical, chemical, catheter-directed foam and ultrasound-guided foam sclerotherapy. Finally, for SSV treatment, thermal ablation is the first choice treatment modality. At Charing Cross in April of 2024, Professor Manj Goel and Dr. Kathleen Gibson announced the results of the VenaSeal Spectrum study. VenaSeal performed similarly to both surgical stripping and endothermal ablation in terms of elimination of truncal reflux. 6-month effectiveness data showed that VenaSeal was not inferior to surgical stripping with similar anatomical closure rates. The equivalent measure was not tested between VenaSeal and endothermal ablation. At 30 days, participation in both the glue closure and stripping arms were similarly satisfied post-procedurally. If we look at an independent market analysis, the blue arrow and the red star, you can see the following. Regardless of the percentages of thermal ablation versus non-thermal ablation, thermal ablation will continue to be the go-to devices for truncal ablation. So let me be the fortune teller. Is thermal ablation the gold standard? Let me look into my crystal ball. My crystal ball says yes, 2019 to 2027. Now let's look at the Ouija board. Is thermal ablation the gold standard? Yes. Ladies and gentlemen, in conclusion, there appears to be clinical equipoise amongst the ablation procedures. No perfect device at present for all superficial venous disease. Cost of materials versus reimbursement, insurance approval, financial incentive, and physician preference is multifocal. Now let's look at some of the new devices undergoing trials. Let us start with percutaneous clamping devices, the secure clamp and a vein closure device. The secure device is a percutaneous device which delivers a clamp through an 18-gauge needle. As you can see, there's a broad range of applications. The first in human safety study with a secure clamp, the average procedure time was less than 10 minutes. High safety profile with follow-up of 12 months, improved quality of life outcomes. There was a need for change of the delivery device to make it single-handed. The trauma application looks exciting in that the secure clamp temporary occluder, known as secure TO, may help to prevent loss of limb, and more importantly, this is an area where non-compressible junctional hemorrhage has a huge role. In the field and under ultrasound guidance, a temporary occluder is delivered. Since it is flexible, it can be taped to the skin. The occluder can be released to establish blood flow as needed. In addition, the clamp may be removed non-surgically. The next device is called the VCD, or the vein closure device. As you can see, there are two bioabsorbable clips that can pass through a 17-gauge needle and takes approximately 6 to 12 months for implant degradation. The target vein diameter is up to 11 millimeters. So let's see how it works and watch the video. It's a very simple procedure. The VCD has many uses, as you can see: Chiva, perforator, veins, truncal stumps, junctional ligation and foam, and truncal recanalization. The first in human trial had 24 patients which were successfully treated. Vein diameters were treated up to 16 millimeters and all great saphenous veins were occluded. There were no major adverse events. On the screen left, it demonstrates an occluded perforator. Let's switch topics and move to mechanical chemical ablation and MOCA. Invera has two different devices under development, one mechanical only, two mechanical chemical. The helical coil macro and micro abrasive surfaces cause cellular disruption of the vein wall. Invera works through three mechanisms. The helical coil abrasive surface causes cellular disruption of the vein wall. The acute response triggers venous spasm, reducing blood flow, and starts the biological healing response necessary for vein closure. The chronic response turns this attached intraluminal thrombostasis into a fibrotic cord, which then fills the lumen. In the pilot study, 13 patients were treated with a significant quality of life HC score at 6 months. 53% showed an ultrasound a significant diameter reduction, with one patient at a complete closure. There were no device-related adverse events. It was a single injection of local anesthesia. Moving on to mechanical chemical ablation, you can see the ablative mechanism in the video, followed by the chemical portion. The pilot study for this MOCA device included 10 patients using 2% polidocanol foam. 100% of the saphenous veins were free of truncal reflux and closed at 6 months. Quality of life and patient-reported outcomes measured improved. Although this device, Sclerosafe, has recently been approved by the FDA and has commercialized into the USA, is important to show. The procedure is pretty standard using modified cylinder technique
to pass the ScleroSafe catheter, which has 2 lumens connected to a double syringe with one of the syringes containing foam sclerosant and the other empty, which is the aspirating syringe, which allows mechanical aspiration of blood and some foam and potentially injury to the vein wall. Let's look at the video. As you can see, the catheter is delivered, and then the double syringe technique will deliver foam and in the other syringe aspirate blood as well. Looking at the registry study in the Red Cross Hospital in Frankfurt, 135 patients with follow-up as long as 1 year occurred. The results at 3 to 4 months, 95%, and at 12-month follow-up, a 90% closure rate. Moving on to the next MoCA device, Wavella, which is a segmental MoCA. The treatment length is 7 centimeters coupled with a drug infusion port. As you can see from the specs, it is quite similar to Claravane, with segmental ablation similar to the Legacy 7 centimeter closure device, with a vessel diameter treatment for 4 to 12 millimeters. Moving on to a different mechanism of action, however not completely, as one of the high intensity frequency ultrasound uses thermal and the other one uses cavitation. The operator positions the treatment head on the patient's leg. The fine-tuning of the positioning is controlled by the system. Echo therapy can be safely applied 2 millimeters from the saphofemoral junction, literally eliminating the risk of stump formation after treatment. The beam can follow virtually any path, even tortuous veins, regardless whether big or small. Once the target path has been treated, the head can be easily moved to the next segment. Very difficult to access veins, such as perforators, can also be treated, even in the presence of an open ulcer. The trial will be completed in June. As you can see, this is an FDA trial. In 2024, Paolo Cassini and group published HIFU in treating the great saphenous vein incompetence, perioperative and 1-year outcomes. They concluded that out of 188 limbs, the great saphenous treated segment shrinkage closure rate at 1 week was 93.3%. At 12 months was 98.3%. However, they also looked at closure and no reflux. As you can see, the closure rate at 1 year was 72%, and without reflux 19.1%, and a total failure in their definition of 8.5%. Switching over to HIFU cavitation, this is a new concept idea for vein ablation. HIFU cavitation works by exciting the small air bubbles naturally present in the veins. These bubbles oscillate until they collapse, effectively scouring and treating the inner walls of the vein. The procedure seems to be easy, with applying the probe to the patient with automatic vein identification based on computer vision and AI safety. This is followed by treating the vein. Let's switch to a different device called a Salutio catheter. This device could be a game changer for thermal ablation. As you can see, the catheter can carry a laser fiber as well as a radiofrequency catheter. Local anesthesia is directed from the needle, which exits the vein from inside out and fills the saphenous compartment. Now let's look at animation. As you can see, tumescent anesthesia is delivered from inside out as opposed to percutaneous, leaving the ablative device in place as the catheter is withdrawn. In the first in-human study, there were 9 consecutive patients. The mean pain score during tumescent was 0.8 out of a 10 scale. There was no serious adverse events. The primary investigator reported that it was safe and easy to use. Thank you again to Professor Fakhri and the organizing committee for the privilege. If you should have any questions that are not answered, please use the QR code, which are my contacts. Thank you.